My name is Dr. Maryl Johnson. I'm one of the heart failure transplant cardiologists at the University of Wisconsin in Madison. And my presentation here at the meeting in Boston regarded the timing of decision-making about when to implant left ventricular assist devices in patients for destination therapy. We all know that there is an epidemic of heart failure and that a lot of these patients get to the advanced stages and we don't have nearly enough hearts to go around for heart transplantation. The option that exists for these patients is destination therapy, LVADs. Most of the destination therapy LVADs to date have been placed in patients that are very ill and sometimes so ill that their outcomes may be compromised by waiting too long. So what we are looking at now is whether we can actually implant the left ventricular assist devices sooner, but still in a way that is safer for the patients. A study that's recently looked at this is a roadmap study. And in this study, they had patients that were actually sick enough to be requiring LVADs, but it was a decision by the patient, the physicians, and the surgeon to decide whether to go ahead. What they found out in this study is that patients that were less ill than the patients that typically have VADs implanted actually did quite well with the VADs. And the patients that had VADs right away versus those that were managed on medicine for a period of time and then transitions to VADs as they became sicker actually had the same amount of mortality. So there was not a survival benefit from the VAD in these less sick patients, although the quality of life was improved. Unfortunately, the complications of the VADs actually were significant, and in fact, adverse events of many different types other than those of progression of heart failure were actually higher in the ventricular assist device group than in the optical medical management group. So in order to actually be able to give VADs to patients with a better safety profile in the future, which will tip the balance toward destination LVAD therapy, we need to decrease the risk of infections with VADs, improve the ability of VADs to be maintained without thrombosis or embolus, and also to decrease the bleeding risks of LVADs. Along with this, the current generation VADs do require a lot of help from a multidisciplinary team, and to expand the therapy further, we need to have better ways of caring for these patients in a chronic way.